All right. Well, I guess we'll get started. All right. Thank you guys for joining to another virtual shadowing session with Hearts for Health. Today we're going to be joined by Dr. Bilbrew. I'll give Dr. Bilbrew a quick introduction. She's a board-certified orthopedic surgeon, subspecialized in hand and upper extremity surgery. So we're excited to have a subspecialty here on board, and we have had quite a few requests for orthopedic surgery. So that's going to be exciting to discuss today. Dr. Bilbrew practices at an orthopedic group with actually the most female orthopedic surgeons in the nation. Over her career, she has earned several awards and honors, including the Pfizer Award in Excellence in Medical Research, the Texas Orthopedic Association Resident Research Award, and the Women in Surgery Conference featured speaker. She's been elected to that. So all in all, we're really excited to have Dr. Bilbrew join us and talk about orthopedic surgery, specifically hand and upper extremity surgery. We're always excited to see subspecialties join us. And as a quick reminder for those who are new or who are just joining us for these virtual shadowing sessions, we have them here where we'll discuss specialties and we'll have a Q&A. So today, this is going to be about hand and upper extremity surgery. Dr. Bilbrew will go through a number of things, but for any questions you have for Dr. Bilbrew that she doesn't already cover, you can type in any questions you have in the chat, and we have the last 10 to 15 minutes reserved for a Q&A. So again, any questions you have, just type them in the chat. Also, if you want to hear more about future shadowing sessions, we have an email listserv. To get added onto that email listserv, you just subscribe to our website. There's a subscription form at the bottom of each page, or you can just email us at our email, shadowing.h4h@gmail.com, and we can add you on to a listserv. Outside of that, I think that's all. So Dr. Bilbrew, feel free to take it away.
Okay, wonderful. Thank you so much, Michael, for having me on. I'm going to go ahead and share my screen so that, is there a way I can show my PowerPoint?
Yeah, actually, let me get that going.
Perfect. And let me know when I'm able to share.
Will do.
Okay.
All right, I think it should be ready to go.
Awesome. Okay, we're going to put this on full screen. And there we go. Okay, so my name is Dr. Letitia Bilbrew, and I'm an orthopedic surgeon. So I'm kind of going to give you guys a background, starting just from medical school all the way to how I got here and how much I love my specialty. And I think it's great. I wouldn't do anything else in the world. So for those of you that don't know what orthopedic surgery is, this is just kind of a picture. This is how we're going to kind of start. So if you look at the picture all the way to the left and you're like, what is that I'm looking at? Those are some of my colleagues doing a total knee replacement. Then as you move along to the right, there's someone that's doing a knee scope, looking at knee arthroscopy. You have pictures of someone who's rehabbing, physical therapy. The Black orthopedic surgeon to the right there is Dr. Claudia Thomas, who was the first Black female orthopedic surgeon ever. She just retired. And then the bottom pictures looking at x-rays, doing templating. And then what you see on the other side again is someone getting ready to replace a joint. So orthopedics really includes so many different fields, so many different specialties, the use of technology. It's obviously very hands-on, and it's about getting your patients to function the way they did before an injury or before arthritis, before other kind of life-changing events. We're all about function and making sure people enjoy their life on a daily basis. So thank you, Michael. You gave me a great introduction. A little bit about myself. I went to the University of Miami for undergrad, Morehouse School of Medicine in Atlanta, Georgia for medical school. I then went and did residency at the University of Texas, fellowship at the University of Florida. And I specialize in upper extremity. So the cool thing about orthopedics is that there's so many fields. You can be a hand and upper extremity surgeon focusing on fingertip to shoulder. You can be a sports medicine physician on sports related injuries. You can be a pediatric orthopedic surgeon. So you only take care of children and teenagers. There's foot and ankle, there's shoulder elbow, there's oncology. So if you have an interest in orthopedic related cancers, there's so many different types of orthopedic surgeons that you can be. There's spine surgeons. And so, people often just think of one thing with orthopedics, but there's so many different areas, so many different personality types. But I kind of want to start from the beginning, which is, this is a virtual session, but, we've had things like COVID pop off, and now people are really starting to question, do I really want to go into medicine? We sometimes see doctors like myself, we're all cheery and happy. But the reality is that sometimes you can feel the way you do in the bottom picture, which is really tired. And I think when you're looking at these virtual shadowing, my job is to make sure that I'm honest with people who are interested in medicine. It's a very long journey, and it starts from the time of undergrad. It's years of studying, and honestly, the studying doesn't stop. And so I still have to read journal articles, and I still read books, and I still study my anatomy. The education never really ends. So though it's not as intense, because now it's just refreshers, but if you're choosing medicine, you have to understand that it is a lifelong learning experience, that during the journey of studying to become a medical doctor, and that's no matter what field, you may miss out on a couple of birthdays or weddings or special events. And the real question is, are you willing to sacrifice those things in order to be in a profession that you give so much of yourself? I will say that I think it's worth it, and I have no regrets, and I didn't really see myself being or doing anything else. So what is the journey of a medical doctor really like? Like I said, I'm starting from scratch. I put up this picture at the bottom right because I think my journey, though I chose to be a physician when I was very, very young, the hard part of the journey really starts in undergraduate, where you're going to be on the computer, learning different things. While you may have friends that are out and having a good time, you're going to be the student that's like, hey, I have to skip that party. I have to skip that event because you're studying for biochem, or you're studying for organic chemistry, or you got to wake up early in the morning and go volunteer it and get your community service hours or shadow a physician. And so the journey is long, and then when you're done with your 4 years of undergrad of having these really, really rigorous courses, then you go into medical school. And medical school I'll never forget my first day of medical school. They said you are going to feel like you were learning out of a fire hydrant. They said if undergrad is more like drinking out of a water hose, medical school is fire hydrant. And that's exactly how it felt. The first 2 years, it is rough, guys. It is not unless you're super, super smart. And I think even the smartest colleagues I know, no one really breezes through medical school. If you're lucky, you might be able to breeze through your undergraduate, your bachelor's degree. You don't breeze through medical school. So medical school is kind of broken down into, I think, of two different areas. Your first is that you have your clinical work. And depending on what school you go to, there's some schools that have kind of condensed it down to 1 year. Most schools, it's 2 years. So it's 2 years of you being in the clinical setting, in the classroom, and you are studying everything you need to know within those 2 years. And your exams are coming at you like multiple exams in a week. Whereas an undergraduate, you would have exams at the end of the semester, or maybe mid-semester, maybe a random quiz. Yeah, medical school, multiple times, different classes. You're learning anatomy, you're learning biochemistry, you're learning pathology. And then after those 2 years, you have to take something called step one. Step one is a huge thing for medical students. It is the first part of your licensing exam, and it is based on those first 2 years of just classwork. Your step one score will determine 80% of whether you're going to get into a certain field. So actually, I take that back. It used to. It's now pass fail. Good for the new generation. When I took it, it was a score just like your MCAT. And if you scored high, you got to go into a super specialized field like mine. If you didn't score as high, it made it very, very difficult. When you all get to medical school, it is pass fail. So somebody out there did a great job of lobbying for that. After those 2 years of studying intensely, the next 2 years, you get your white coat and you are out doing clinicals. So now you're learning internal medicine, pediatrics, emergency medicine, surgery, all those different broad fields, OB-GYN. This is where you're catching babies and learning how to do injections and drawing up medicine. And it's still like learning out of a fire hydrant, because you're now having to take the application of what you thought was the book smarts, and now you're learning all new things. But what's great about these 2 years is that this is where people start to really see what they like. You may have gone into medical school thinking, hey, I want to be a surgeon. And then you get on a pediatric rotation and you're like, wow, I love this, or the opposite. I had friends that swore up and down that they were going to be an OB-GYN, they were going to deliver babies. She's a breast surgeon today, so it just really depends. Those 2 years of getting exposed are really crucial. And then you take your step two, which is the second part of your licensing exam. And not to say it's not as important, but step one is the big one. From your fourth year, you then determine what you want to go into. And so you start to do what's called away rotations in just that field. You set them up and you're almost interviewing for your job, your first job as a physician in residency. Residency is what you go to after you complete medical school. And depending on your specialty, it can last anywhere from 3 years to 7 years. So the 3-year programs are things like pediatrics or internal medicine, family medicine, emergency medicine. OB-GYN tends to be 4 years. Surgery, all specialties, is 5 years. Once you complete your 5 years, then it is fellowship. And luckily in orthopedic surgery, it's really just a 1-year fellowship unless you choose to do research. So that is the full journey. Really want you guys to know that, because I went from undergrad thinking that when I was done with my 4 years of medical school, that was it, and I was going to go out and practice medicine. That's not what happens, guys. There's a lot more that goes into it before you actually become a licensed physician, even after you complete your fellowship, right? So we've done 4 years of undergrad, 4 years of medical school, specifically for orthopedics, 5 years of orthopedics. If you're a subspecialist like myself, a 1-year fellowship. After all of that, you have to then pass your written boards, okay? And this is any specialty. And then you have to go out and practice in your field, collect cases, and then pass your oral boards. And then you're board certified, fully functional orthopedic surgeon. Oh, wait, there's more. And then if you want to become specialized in hands, you have to take an additional exam, which is called the certification of additional qualification. Then there's more. Then every 10 years, you have to recertify and take a test to get board certified again. So guys, it doesn't end. So this is why I really want you to know that full journey going in. And, that's mine for orthopedics, but it's pretty similar for any field that you go into. So is it worth it? On one side, people see you as a hero, especially during COVID. Oh, doctors are heroes. They're great. They're here to help. And then the part that, no one ever really tells you about is the cost of student loans. I left medical school and undergrad with about $380,000 worth of loans. That's a lot. unless you are smart about financial planning, or maybe you've gotten scholarships. During this pandemic, there's been a huge thing on physician burnout, where doctors have just gotten tired because they just feel like they can't see the patients and still enjoy it. Then there's, what if you're sued? The amount of years that go into studying, you're going to see that your friends will be done with undergrad and maybe even done with a graduate degree, and they're out there, they're making a salary, and you're still sitting here at making resident salary, which isn't that much. But again, I think it's worth it. I love what I do, and I have no regrets. So again, orthopedic surgery, before we get into the patient vignette, consists of multiple fields, okay? Multiple things that you can go into. So never really think that I can't be an orthopedic surgeon because I'm not a sports guy, or I don't like sports, or I'm not big and burly. Every field has its stereotype. I think I surpass that stereotype. I am 5'3". I'm not super muscular. I didn't play sports in school. I don't really watch a bunch of football. If you think about, and when people think about an orthopedic surgeon, they think about the guy that, was quarterback in college and is 6'2" and super muscular. Not true. Here I am, and I know all shapes and sizes of orthopedic surgeons. If you want to be a pediatrician, everyone thinks that, oh, usually that's the cute little girl in class. And I know guys that are 6'2", 300 pounds, they're pediatricians, and they love taking care of kids. So when you do choose to become a physician, or choose your specialty specifically, never let the stereotype dictate what you go into. Let it just be if you enjoy it or not. Okay. And then if you have a bad day, even for me, I've been on orthopedic rotations when I was a student, where I was like, man, I'm just not feeling this today. Like, I am tired. I don't find this interesting. I still didn't allow that to deter me from going into the field. When I was a student, all I got exposed to was joint replacements, knee replacements, and hip replacements. Guess what? I'm an orthopedic surgeon, and I cannot stand hip and knee replacements. I would not lose a wink of sleep if I never did a hip or knee replacement ever again. I haven't done one since I finished my training, because I don't enjoy it. Okay. I do enjoy hand surgery and elbow surgery and shoulder surgery. So it's almost like, just like in life, you have to get through those major barriers to finally carve out the life that you want and create the life and the field that you want. So never be deterred just because there's not something you don't like, something you don't like about a particular field. Always continue to persevere, push through, before you make any rash decisions and say, this isn't for me. So now, Michael, if that's okay, can I move on to the patient vignettes and kind of let's talk about some orthopedic hand cases.
Yeah, definitely. We're happy to dive in.
All right. So this is my first one, and it's called I Punched a Wall. As a hand surgeon, this is always going to be a part of the experience. And I tell you already, I punched a wall is, sorry to stereotype, 90% of the time it's a guy between the ages of like 14 and 30. You get upset, you punch a wall, and I say, who won? The wall's going to win every time. You're just not going to win. It is going to be pathognomonic for a metacarpal fracture or boxer's knuckle. So here we're looking at, in orthopedics, we take x-rays. We got to always take x-rays. And I'm looking at what I would call an oblique view of the hand. Okay, so you got the thumb and all of the fingers. The metacarpals are these long bones here. Okay. So this is the thumb, index finger, long finger, ring finger, small finger. This patient of mine was 17 years old. He didn't even have to tell me he punched a wall. I knew it, because that's the only way you can really get that break, is if you impact it. And he had pain, couldn't move his little finger, and of course, finally confessed, I punched a wall. And when that happens, you have a fracture. Now, here's what you guys should always remember. Take home this. Fracture and break is the same thing. Fracture is the medical terminology. Break is the layman's terminology. So when some people are like, well, I heard it was fractured, but it's not broken, just say that's the same thing. Okay, I hear it all the time. We know this is a nice, young, healthy patient by just looking at the density of their bones. And you can almost kind of see where their growth plates were, indicating that this person is towards the end of their adolescent years. Growth plates are where your bones grow from. So what are the options for treatment when I have someone come in and they've broken their bone like that? So you can either say, okay, we're going to leave it alone. That's what we did 600 years ago. Honestly, people function fine. They just had a weak hand. You can cast it, okay? But if you cast it in this position, it's going to stay and it's going to heal just like that with a big old bump there. The other options, you can put it in a brace. The same thing's going to happen. And then the last option is surgery. And really, that's when the bone is that angulated, that's the best thing to do. What's really cool about this surgery and what's cool about orthopedics in general is that we're always coming up with new technologies. So all the way up to last year, the way I would fix this fracture or break is I would make a cut on the top of the hand from about here all the way down to here, move the tendon out of the way, scrape down to the bone, put clamps on the bone, and then put a plate and screws. It was pretty major. You had to keep them immobilized in a splint, which is like a form of a cast, for like 4 weeks. They couldn't move it. And then you take them out the cast. Then they have to do like a month of therapy, get their fingers moving. They're really stiff. You can't lift anything heavy until this new technology came out. And this is a screw, guys. It's a screw that's actually going down through and into the bone. And to do this, I make a little cut, literally 1 centimeter, right off over the knuckle, pass a wire, and I'm looking at it through an X-ray machine to make sure the wire goes down through the bone. I then size it. I measure how long the wire is, and then I put the appropriate size screw over the wire. The patient can move their hand the immediate day, that same day, and it's safe for them to start picking things up. And that's exactly what this young man did. He had no pain. He didn't need any pain medication. He didn't need any therapy. It was wonderful. Okay, vignette number 2. I get really interesting patients as my hand patients, because we need our hands to work, right? So this was actually a retired gentleman, and he said, I make Japanese swords. And I'm like, okay, well, what does that mean? Well, we're all about function. And he came to see me because he was at risk of cutting himself because he couldn't grip. And so we try to figure out, well, what's going on with your grip? His motion was great. But then when I got an X-ray, and this isn't his X-ray, obviously, just to keep the patient's information confidential, but this is what his knuckles look like. So this marks the area of your knuckle. This is your thumb here. This is your index finger, long finger. And if you look over here, over on the ring and small finger, this is what we call the metacarpophalangeal joint, right? And there's space here, okay? Then you move over here and there's no space. That's what arthritis looks like on an X-ray. And when that is happening, you have scraped away the cartilage. Your body has degraded the cartilage. Cartilage is what covers bones. And now you have it bone on bone, and it's very painful. It's going to lead to a decrease in motion, weakness of grip, pain that's worse in the morning because we've been keeping our hands still. So, now what do we do about this? He's like, I've tried medication. I've tried exercise. It's not working. When you're bone on bone and you're arthritic in orthopedics, you really have 2 ways to deal with that joint. And you guys can remember this from now until if you ever become an orthopedic surgeon. We have 2 ways surgically to deal with arthritis. The first way is we fuse the joint or do what's called an arthrodesis. That is where you make 2 bones, 1 bone, and you have to put a plate and screw to keep it in place. When you do that, you no longer can move that joint. It means that you would cut, where's my cursor? There we go. You would cut off this portion of the bone. You would cut off this portion of the bone. You put a plate and screws on top, and you make the bone grow together by pushing the 2 bones together. You don't have any motion, which means that he wouldn't be able to make a fist. He wouldn't be able to hold anything. Obviously, if this gentleman makes Japanese swords, that's not a great option. The second way that we deal with arthritis in orthopedics is that we replace the joint. And that's what I did for this gentleman. He had failed anti-inflammatories, injections, bracing, therapy. He needed surgery. This is a picture of the joint, okay? And what I did was we cut out the arthritic portions of the joint and I put in a plastic joint. So this is like a silastic type of plastic material, very, very, very durable. And this is what bends. Okay, it's important in surgery that I keep the ligaments intact so that it's not unstable. And the x-ray at the bottom is what it looks like when it shows up on x-ray. Afterwards, he could make a full fist. He didn't even need any therapy himself. He's able to move the finger straight away, right back to making Japanese swords. Okay, last vignette, and this makes a huge part of my trauma. I cut myself. Here's the key, a week ago. And I'm like, okay, a week ago, you come into my clinic, but the finger looks like this. So in this patient, and the cut was tiny. It was, I mean, just like barely anything. Unfortunately, this patient also had a history of being pre-diabetic, or in other words, the patient was a full-blown diabetic, but did not know, was not on the appropriate diabetic medication or insulin. So his blood sugars were completely out of control in the 600s when they should be probably in the 120s to 100s. When that happens, bacteria feed on sugar in the blood. And bacteria that typical person that, you know, we just wash our hands, it will go away. That bacteria seeded from that tiny little cut, and it was a paper cut, it was small, went down through the fat in the finger all the way down to the tendon. This is called flexor tenosynovitis, and it is one of the few emergencies in orthopedic surgery, and specifically in hand surgery, because you can lose your finger because of this. When this shows up, the patient is going to have extreme, exquisite tenderness to light touch along the finger. They won't be able.
I think you freeze for a second.
Mm-hmm. Oh, internet connection's unstable.
Yeah, we can hear you right now. It just freeze for a second. If you could just backtrack like maybe a sentence or two ago.
Sure. So with this finger, there are what we call pathognomonic signs of a flexor tenosynovitis. The first one is what we call fusiform swelling, which is that sausage, thick swelling of the finger. It can double in size. The second one is pain with any motion of the finger. The third one is tenderness along the finger. And then the fourth one is it's usually held in a slightly flexed position because of the bacteria and what is going to be pus in the finger. This is one of the few orthopedic or hand emergencies. The patient needs to go emergently to surgery, or the patient can lose their finger and potentially it can seed into other fingers. So like I said, the only option for treatment is surgery, 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 surgery. What you see here in the top left finger is a example of what's called a Brunner incision. And we cut the finger in this way, as you'll notice at the corners of the creases, to prevent the finger as it heals from contracting. What you're looking at here, this yellow stuff is the fat of the finger. The white stuff is the flexor tendon, and then the highlighted white stuff are things called the pulleys. This is where the bacteria comes underneath, and that would be filled with a really thick white pus. You have to wash it out, take cultures, figure out what it's growing, close the skin. It typically heals very, very nicely, and then keep them in the hospital for a few days to make sure they can get IV antibiotics. So one of the few emergencies that we have where you got to stop what you're doing and make sure they can get on your schedule within 24 hours. So again, why choose orthopedic surgery? It's a challenge. There's always something different. There's always a different surgery, different patient. You get to use your hands. It's hands-on. There's a great lifestyle of, getting to talk to interesting people like a Japanese sword maker. And you really do feel like you're making a difference in the lives of others because you're returning their state of function. Whether it's I had difficulty walking because of pain, I couldn't hold an object because of pain, or I have this rip roaring infection from a tiny paper cut, and now you've potentially saved my finger. Wonderful lifestyle, wonderful practice, really interesting patients. Wouldn't change it for the world. And again, just think about all of the cool things that you can do. Okay, we can go to questions. That's my presentation, guys. Thank you so much.
All right. Well, thank you so much again for going over these patient cases. Also, a lot of questions that often come up are over why a certain specialty. So in this case, why orthopedic surgery. It's always great to hear, the reasons behind it. And yeah, it definitely must be a challenge to adapt with cases. So maybe we can start it off by talking about, since we covered patient cases, just a general overview of what orthopedic surgery is and what you can expect in terms of the challenges that you face as a physician. How can students, as undergrads today, possibly dip their toes into involvement or more exposure to orthopedic surgery?
So if you're an undergrad and you're trying to get exposure to orthopedic surgery, the best way is just to find your community orthopedic surgeon. I have hosted high school students before that have came into the clinic and they're able to absorb me, and even not necessarily take part in procedures, but see the procedures that I do in clinic. So that's one way, is you can literally just Google orthopedic surgeon, call the office and say, are you taking high school students? The other way is, or excuse me, undergraduate students. The other way is, if you're at your college and they have sports at your college. If your college has sports, there's going to be an orthopedic surgeon on the sideline somewhere. So track down the team physician, and they usually will have access to who the orthopedic surgeon is, and you can chat them that way. Not necessarily just football, that's really any sport. There's typically an ortho doc that is available just to help out with any injuries.
You mentioned a few challenges there just with dealing with patient cases. There's almost similar to kind of other specialties, there's always going to be unique things that you see day to day. So it's not going to be the same mundane work. But outside of what you mentioned already, are there any other challenges that you find really exciting and compelling to the specialty?
Yeah, so I think one of the main challenges is that everybody is slightly different, right? So you sit here and you study the approaches to, let's say, the distal radius, the approaches to the wrist, or maybe the approach to the thumb, and you're like, okay, this is going to be just like the book. And you look at someone's thumb and it looks nothing like the book, And I still, have to be in practice for 10 years where I've done an approach 1,000 times. We'll get into one, and I'm like, whoa, there's aberrant anatomy, like the patient's tendon is all the way over here and I'm used to seeing it over here. And so it keeps you on your toes with orthopedics. When you have the privilege of, cutting on someone and putting a scalpel to somebody's skin, you don't do it just with, like, okay, I'm just dispensing medication. You have to be cognizant that, God created everyone a little bit differently. And the way that I can literally have 10 wrist fractures that I'm going to do in the day. None of them are going to be the same. Everyone is going to be slightly different. And that is a challenge because it is easy when you're doing something. If you think about any job, like let's say that you're working in checkout, you're checking out. It's the same thing every time. Orthopedics is nothing like that. You're going to be surprised at things all the time. I just saw a patient today that, she had bruising on the top of her arm, and she's like, where did that come from? I'm like, I have no clue. You get stumped too, which is totally okay as a physician and a surgeon to be like, I don't know what's causing that, but let me get you for a second opinion.
Definitely. And you earlier on went through kind of just the general structure of curriculum with most medical schools, but having gone through 5 years of orthopedic residency, could you take us also through how there might be variance with what you do year to year through those 5 years? So could you just take us
Sure.
through the timeline of it?
Sure. So your first year, which is called your intern year, you're going to be doing at least 6 months of other specialties. So usually this is things like general surgery or ICU or emergency medicine, sometimes even radiology or internal medicine. They do that because you're about to spend the rest of your life being specialized in orthopedics. And then you'll do 6 months on your ortho rotations where you're just kind of rotating on different services. Typically, and every program is different, but they're going to make sure that every year you get exposed to foot and ankle trauma. That's a huge one. That's really where you develop a lot of your skill set. Sports medicine, spine, hand. And then if your program has oncology, you may spend some time on oncology and pediatrics. Those aren't as big because oncology is super, super specialized. You don't really get to do a lot as a resident. And the same thing with pediatrics, you don't really get to do a lot of operating as a resident, but the other fields you do. So you're going to get exposed to those 7 different areas, which is also what's going to help you determine what you want to specialize in.
Definitely. With a few specialties we've had in the past, there have been speakers who have talked about multiple ways of getting to that specialty. So instead of just a certain residency and then a fellowship following that, there might be multiple residency routes that lead to the same fellowship. Is that the case for hand and upper extremity surgery?
It is for being a hand surgeon, you can be an orthopedic hand surgeon. So you do your 5 years of orthopedics. You can also go to be in hand surgery if you're a general surgeon, and also if you're a plastic surgeon. So that's what's kind of cool about hand surgery is that there's 3 different ways to get there. I will say the most common way to get there is, and I'm biased because I'm an orthopedic hand surgeon, but the most common way to get there is orthopedic surgery. And I would say if someone is interested in orthopedic surgery and hand surgery, that's the best way to go because when you're an orthopedic surgeon, you're going to, through your 5 years of residency training, get exposed to working on the forearm, the elbow, and the shoulder. And I think it makes you a bit more marketable when you are able to operate on the entire upper extremity rather than, just maybe the hand.
And we have a few just some general pre-health students here. So outside of pre-meds, there are some pre-PA students, some possibly pre-nursing students who join us. And it's also great just to cover kind of the involvement on that side of things. So in the practice of hand surgery, are there involvement with PAs, with nurse practitioners, with fellow kind of healthcare professionals? And if that's the case, what do they usually do? What are they limited with in terms of their scope?
Oh, absolutely. PAs are a huge part, and nurse practitioners are a huge part of an orthopedic practice. The physician that I trained under has had the same PA for about 20 years. That's the person that is with you in the operating room helping you to retract. They typically, after spending that amount of time with you, know as much information as you and can probably diagnose just as well those conditions. So we work very closely with those other professions, especially doing things like running clinic. A PA can have their own separate orthopedic clinic where they're seeing postoperative patient or just following up on patients or even seeing new patients and then funneling them to the surgeon for operative intervention. Same thing as nurses. There are ortho nurses that work in the hospital that only work on the orthopedic floor. And these nurses are the ones that know how to do the dressing changes for the hips and knees. They understand the protocol. They know what looks like normal skin after a surgery versus abnormal. They're great at putting patients at ease who maybe the patient, this is their first knee replacement, but that nurse is like, yeah, I've seen thousands, you're doing fine. It is, I think with other nurses, it's easier. They can switch between, maybe they do a little bit of internal medicine or someone that's there for high blood pressure or maybe diabetes, but an ortho nurse is an ortho nurse, and they claim that as their own thing. There are courses just to be an orthopedic nurse.
I mentioned earlier with the introduction that you've been awarded with quite a few awards, like the Pfizer Award in Excellence in Medical Research, and quite a few others. You've been featured as a conference speaker earlier. Part of the whole just admissions process the process of being involved as a healthcare professional through the whole journey, like you mentioned, it's a lifelong experience. So you can still do this as an attending, but is involvement outside of the classroom, outside of reading textbooks, outside of training in general. So that includes research, awards, like you mentioned, just extracurriculars in general. For those who aren't as familiar, just being an undergrad, we're kind of starting the whole journey. There's years ahead for us. But for those who are not necessarily as familiar with how to get in tune with those, how to hear about those opportunities, how to connect with other people, how to present yourself as competitive for that. Do you have any advice for them?
Absolutely. So I tell my mentees that your network is your net worth. So, this isn't a field where you get to stay in your cocoon and be a hermit. You got to get out there and go to some of these conferences. So there are a lot of medical conferences for undergraduate students. And even if they're not, you can register as just an extra person. Let's say you want to go to the American Medical Association's yearly conference. You can go as an undergrad, and they will have programs for undergrads. There's something wonderful called Google. Okay. Get on Google and research it. I did not have that. I'm not dating myself here. Yes, the internet existed when I was an undergrad, but there weren't as many resources. Like now, when people ask me that, I'm like, literally go online and type in resources for undergrads interested in going into medical school. It is going to bring up 10 pages worth of stuff. A lot of the conferences and these societies out here, like the American Academy of Orthopedic Surgeons, or the Academy of Pediatricians, they have programs specifically for undergrads, and we're looking for them. We're like, okay, where are they? They just don't know. They don't apply for them. So there's always things out there. You do have to be proactive. And I tell you what, if I have to convince you to be proactive, and this is probably not the field for you, because that's a part of medicine, is that you got to go out there and do your own research. And so do it.
Yeah, nothing more to really add after that. I guess some people really just at this thought of going to orthopedic conference, they get kind of intimidated that that might be just for residents, just for medical students. But yes, just like you mentioned, being proactive and just taking the chance. You miss 100% of the shots that you don't take. It's still a cliche, but very true. Moving on to kind of your clinical practice outside of just the admissions, the advice that you have for students, in terms of the advances with hand surgery, for example, with patients that have gangrene in a finger, are there ways that they can save these cases that they're coming, up with more innovation? I'm sure research is always expanding. We learn more through it. So what are the advances and innovations looking like in hand surgery?
Yeah, so I think the best one has been with endoscopy. Endoscopy meaning going in with a small camera. So, individuals who have things like a carpal tunnel, where 15 years ago, we had to make a really large incision all the way down to view the carpal tunnel. This is where the carpal tunnel is. And now we can make a 1 centimeter incision either here or here, go in with a camera and do the exact same surgery. So with hand surgery, everything is moving towards a very minimally invasive approach. And that's because the hand is one of the areas that when you operate on it, it tends to swell. It's the very last part of our body. We tend to keep our hands down. And so swelling then leads to decreased motion, which leads to decreased function, which leads to increased pain. And people can't do what they want to do. So minimally invasive is a huge thing. The other thing is just the technology with plates and screws, and in the vignette that I showed earlier, where we're now realizing that instead of having to make a huge incision to fix a bone, we can make a tiny incision, use little clamps, and put a large screw or a rod down there and get people moving. So that's absolutely another innovation. Well, in surgery in general, we're always looking at ways to improve pain management. And so that's almost like an offset to orthopedic surgery. But how can we get people off of narcotics sooner? What cocktails can we use when they're in surgery, whether that's something we're giving them IV or something we're infusing around the incision with like a little wick that's going to give a little bit of numbing medicine over time so that they don't have to consume narcotics, which can lead to addiction and constipation and just nausea and things like that.
And speaking of other specialists with pain management, I know that that's its own kind of subspecialty. And also there's other ones like rheumatology. Maybe it might have just started with the primary care doctor and they found something, they passed it and referred it along to an orthopedic surgeon. With that said, what are the other specialties that you're in common contact with, that you're in close contact with in your practice?
Sure. So every orthopedic surgeon's bestie is going to be the anesthesiologist. This is the person getting our patient through the case. So we're like this together. We have a love-hate relationship. It's like boyfriend, girlfriend. You got to know and keep a great anesthesiologist. As a hand surgeon and as an orthopedic surgeon in general, rheumatologist. So this is where our arthritis patients, a lot of them are coming from. Family medicine, that's our huge referral source, where you have a great family medicine doc who's not putzing around and trying to treat something. They're just like, I know what that is. Go see your community ortho doc. For me, the neurologist, that's the person who's going to pick up on my nerve compressions, like my carpal tunnels and my cubital tunnels, the person that's going to do the EMGs. Physiatry, that's a field that a lot of students probably have never heard of, or physical, medical, and rehabilitation doctors. They specialize in people with muscular ailments or who are trying to rehab after a major surgery or after a major injury. When I can't treat someone with surgery, but I know they have some kind of musculoskeletal issue, I will send them to a physiatrist.
And also in terms of cancer cases, so with cancer in the bone, do you work with oncologists? Do you see any, frequent cases of cancer that happen to be in the bone as a hand surgeon?
So as a hand surgeon, I typically don't. If I'm finding a mass, it's usually benign. If I find something and it is an isolated hand issue, which is pretty rare, I will take it out myself and I will send them to an oncologist. However, if a patient is presenting with a tumor in the hand, it is most likely a metastasis, meaning it's moved from its primary source to the hand. And the most common cancer to do that is lung cancer. So when I see something funky going on in the hand, it is my ethical duty. I send them to the oncologist, absolutely. And then the oncologist will then set them up with the orthopedic oncologist.
You mentioned medicine as being a really lifelong experience. As an attending, people who have done residency in the 70s and the 80s, they're still checking and staying up to date with resources like research, the latest publications. So outside of that, there's also CMEs. Can you just take us through what resources you have as an attending and what resources you think have been most effective in terms of continuing education?
Yeah, I think the most effective thing for me is that I aligned myself with a hospital that has a residency program, even though I'm in private practice. And what that has allowed me to do is to have full access to a medical library. You all that are in undergrad or in medical school right now, you probably take for granted the fact that you can just walk into a library or hop onto the online library and look up any journal, any book, any whatever. Believe it or not, that costs a lot of money to be able to get access to every single thing. When you're done, when you graduate, you don't, and you have to pay a subscription unless you are like I am. I like an adjunct faculty residence, and so having access to their library. And honestly, I think my connection says unstable, so I'm going to pause for a second. There we go. And honestly, always teaching keeps me on top of things. Always being able to be in a position to teach residents or medical students, it makes you want to look up your own information. Like I have students that shadow me, and I'm like, well, let me make sure I look up this again, just in case they ask me a question and I get stumped, because we can sometimes forget or the pathophysiology of something. We're like, we know how to diagnose it. Don't ask us how we know it. We know it. And so just being in a position to always be an adjunct professor has helped me to keep everything sharp.
So you talked already about just with generally referrals or just passing along the word, work amongst multiple subspecialties, but in the OR, when you are doing surgery, specifically with the hand, are there procedures when you need other subspecialists, other surgeons in that same room, like for example, vascular surgery?
So, as far as working with another surgeon in the room, it's, I really haven't done that since training. And that's because the surgeries that require another surgeon are usually oncology, that will require someone like plastic surgery or spine surgery, because the spine surgeons will sometimes require a general surgeon to go through the abdomen and move those things out the way so that they can get to the anterior or the front of the spine. Otherwise, you cherish those moments in residency where you get to have, like two medical students and a resident and attending, and it feels like this wonderful team. Because when you get into practice, it's just you by yourself.
Yeah, that is true. Sometimes the hardest times might still be the best memories. Uh,
Exactly.
yeah. In terms of where you do those procedures, so you mentioned the OR there, but do you ever have just small procedures that you might do in, like, let's say, the outpatient clinic?
In my outpatient surgery center, I absolutely do. In the clinic, not so much, but that's just because my practice isn't set up like that. But there are many hand surgeons who have set up their practice that they have a room in their clinic that they can do simple procedures like a trigger finger or a carpal tunnel or nail removal. It's absolutely plausible to be able to do those things.
And just looking back, I know it might have been, a few years having gone through residency already and now as an attending, but looking back to when you were working to get into medical school, we have quite a few pre-meds join us, and a common question is around medical school admissions. It's an interesting topic and one that we really can leverage and make use of at this point in time of their career. So looking back to that point, what do you think really gave you the leg up in terms of admission? Was it research? Was it extracurriculars? In your case, what would you really think or recommend as something to take advantage of that isn't as, I wouldn't necessarily say popular, but isn't as, it's underrated, I would say, right? Something that's not as well utilized as it should be.
Um, I think honestly, in this age, you just need the scores to get you in. And what made me stand out was my personality. What we do when we're looking at CVs and resumes is we look at it just barely, but what we want to do is have a conversation with the student or with the resident. And if that conversation is bland and you have nothing to talk about, then you're going to be boring and the patients as a physician and to your patient. And so what interests you outside of research? Because guess what, unless you're going to be a researcher, you're not going to do research every day. You're a physician, right? You're not going to volunteer all day and every day, because you're a physician. So what do you enjoy? And I spoke about what I enjoyed, just everyday life. I enjoyed my family and I enjoyed music and art and traveling, and I had hobbies outside of medicine, and that's what I talked about. I talked about who I was and not necessarily what I was doing at that moment in time, because we know every student, what you're doing is preparing to be a doctor, like everybody else applying to medical school. Who are you? And I think that takes some introspection. And if you arrive to the point where now you're in your junior year or your senior year and you still haven't figured out what you enjoy, you might want to consider taking a year off to develop that in yourself, because this is the most free time you're ever going to have.
Yeah, definitely. And just with the last few minutes that we have, it's always great to look at kind of different avenues, niche fields of interest, even if it might not be necessarily in clinical practice, that physicians are diving into. So I know that you have founded your own consulting service. Can you just take us more about what brought up that idea? What was the initiative behind it, and how you like to express your interest through it?
Sure. So I brought that up, honestly, as a way to help educate other people about, just the medical field, and not necessarily if you wanted to be a physician, but it was really a conduit for being able to give out scholarships to whatever it may be. So, let's say that you wanted to go to be a scrub tech, or whether you wanted to go to nursing school. I wanted to have a platform to be able to talk to people about, persevering through whatever they want to do. I think when you have the mindset of, I want to go to medical school, you have a little bit of grit in you. But what about the person who doesn't quite want to go to medical school? Maybe they want to be a PA or a nurse, or maybe they want to be a pharmaceutical rep. And so it was a platform to kind of get people into the medical field and the health profession. That was one field of it. The other part of it is I use it to start to talk about diversity and equity and inclusion, and educate different businesses, especially specifically within healthcare, such as hospitals and practices, how to incorporate DEI, diversity, equity, inclusion practices into their business to make sure that they're fairly treating both their patients and their employees.
With your specialty being chosen as hand surgery, I'm sure there was kind of a process, a timeline in terms of the exposures you had. I have just two last questions, kind of just to end off the hour. The first being, when was that deciding point in the timeline of going through medical school and eventually deciding before matching into residency that you said, I want to go into hand surgery, or I want to go to begin with in orthopedic surgery? And the second question is about your choice to pursue a fellowship. So we do have some subspecialists on here, or we also have the physicians who have just done a residency, have concentrated on the specialty they started out with in training. When did you also make that further decision to get into hand surgery specifically? Was it at the same point that you decided to do also orthopedic surgery?
So I didn't even know what orthopedic surgery was when I started medical school. I had no clue, had never heard of the field. And I had this wonderful, I was a first year student, and this amazing, beautiful Black female orthopedic surgeon came and did a lecture. And she dressed really nice. And she was super smart, very charismatic, and it was like that. Her name is Dr. Simpson Mason. If you're into the field of orthopedics, everybody knows her. She's everyone's mentor. And she was the one that said, if you want to do something difficult, but enjoy it, this is the field for you. And that's how I knew it. I was like, I'm gonna be an orthopedic surgeon. That's all I needed to hear, was someone to challenge me to say, this is hard, but it's awesome. I was like, yeah, hard arson, that's me. And then I just so happened to love anatomy, and I knew I wanted to be a surgeon, but the combination of anatomy and function is really what made the difference. And that's how I started to get exposed, which is really late. Most people kind of go into medical school, they already know about orthopedics, they already know someone that does it. I figured out very late, and made the real decision my third year, which is like when you have to actually decide what you're going into. As far as hand surgery, again, I didn't even know that that was a thing until I was in residency, and I got to do a rotation with some hand surgeons in the community. And I love the fact that, number one, they got to sit down during surgery. I had just got off trauma and joints where I'm standing up and I'm sweating. And yeah, it's fun, but you go to hand surgery, you get to sit down. You get to operate on babies. You get to operate on old people. You can operate on a fingertip. You can operate on the elbow. It was so many different types of surgery, and I really loved it. And then the last question is, doing a fellowship. Doing a fellowship was, to me, an economical decision. I knew that I wanted to practice in a major city. And in order to do so, I had to stand out. I couldn't just be a general orthopedic surgeon. Kind of dilly-dallying and everything. I had to have a niche. I had to be able to stand out and be marketable. Of course, I loved hand surgery, but the decision to do a fellowship, especially because it was only 1 year, was financial. I wanted to come back to Atlanta or Orlando. That's where I grew up. And there are no general orthopedic surgeons there that were young. Everyone had been practicing for 40 years. So for me, it was a way to distinguish myself and make sure I could get a job once I had finished my training.
All right, well, I think that's the perfect point to end off on. Again, thank you so much, Dr. Bilbrew, for joining in. Just the last few things for those who are listening to us before we end. So to gain an hour of virtual shadowing for your attendance today, You just have to complete the quiz. We've posted the quiz link in the chat. And also, if you go on our website, it's available on the virtual shadowing page. If you pass the quiz, the minimum 60% or above, you'll be sent an email with a certificate with your name on that certificate to certify you with those shadowing hours. The email will be the same one that you use on the quiz. So just make sure that you use one that's convenient for you. And this quiz will be due at 11:59 p.m. Central Standard Time on this upcoming Wednesday, March 23rd. And if you don't happen to find your certificate in your inbox, just check your spam folder or feel free to email us. Also, next week, we'll have Dr. Clapper on Thursday, March 24th at 7 p.m. Central to talk about clinical nutrition. We'll get a new specialty on board. We haven't talked about that one so far, and we haven't even talked about orthopedic surgery. So it's always great to see some new specialties that we've added on here. Again, thank you so much, Dr. Bilbrew. It's really exciting to see the cases, talk about orthopedic surgery. I've learned a lot. I'm sure I can say the same or speak for the audience here and say that they've also learned a lot. And thank you so much for addressing the questions. For those who might be interested in hearing more from Dr. Bilbrew, you can follow her on Instagram if you would like to give your Instagram handle, Dr. Bilbrew. And yeah,
Yes.
that's all.
Yes, my Instagram is my first name, last name _ MD. So that's Letitia Bilbrew, LATTISHA, last name Bilbrew, BILBREW _MD.
All right, sounds good. Follow her there if you're interested in hearing more from Dr. Bilbrew. Yeah, we're just really happy to have you here. And we're so glad that we could talk about this subject here. So hope everyone has a great night. And again, thank you.